Okay.
Yep. Yeah, that was the question I struggled with the most because I was like, I don't like these three. I would like to choose other things.
You know what? Olsik did the same thing. So if you want to go off on your own, you are perfectly entitled to do that.
Fair enough.
You can just say, I got my own ideas about this, so let me answer the question. So go for it. Hello and welcome to the Fire Chief Podcast, the only podcast dedicated to the Chief Medical Officer. I am your host, Lee Scheinbart, and this podcast brings you stories and wisdom from some of the best CMOs in healthcare today. The leaders on this show face some of the toughest challenges in healthcare today, and they will share with you their insights about the role and the responsibilities that come with the title of Chief Medical Officer. Today our guest is Dr. Elizabeth Warner, Chief Medical Officer at Cherry Health in Grand Rapids, Michigan. Dr. Warner grew up in Cedar Rapids, Iowa, and she earned her undergraduate degree from the University of Minnesota. She earned her medical degree from Michigan State University's College of Human Medicine and completed an internal medicine residency with AOA distinction with the Kalamazoo Center for Medical Studies. Dr. Warner also has the distinction of being a certified physician executive through the American Association for Physician Leadership, and she is on the faculty of AAPL as well, where she teaches the subjects of strengths-based leadership and appreciative inquiry, among others. Elizabeth, welcome to the show.
Thank you. I'm so happy to be here, Lee.
It's a pleasure. Do you remember the first time we met?
I think we were on a panel together.
That's exactly right. Do you remember who the moderator was?
Oh, remind me. Was
Dr. Mark Olsik.
Yeah.
If it weren't for that panel and Dr. Olsik, we probably would not have had the chance to get to know each other. And then while we were together, we all went out for dinner in Chicago that night. Do you remember that?
Yeah, it was a glorious night.
Yeah, it was. It was also clear over dinner that CMOs are underappreciated, undervalued, and of course we were a biased audience of an echo chamber of ourselves. But I think you might agree that we were all looking for ways to connect and to discuss things that are important, particularly to chief medical officers. And if that had not happened, I'm not sure that this podcast would have ever launched. I don't know if you have any additional thoughts on that.
My reflection I would just add that I think regardless of the title, as you ascend in leadership and you have clinical expertise, there is a distinct loneliness that can happen. You might be VPMA or whatever. You might be a medical director, but really doing CMO-ish type work, depending on the organization. But there's a risk for isolation because of the dual role, but also just the things you're trying to manage. And so to echo back to, our enjoying our meal together, and then also just being able to say we're not alone. We can see ourselves in these other folks, and some of the challenges that we are navigating are more universal, which gives us a little bit of resilience to go back in the next day and keep working.
Yes. It might be more than resilience. It might be self-punishment too. But it was very well stated, and I would agree with everything you said. I suspect that along the way, you've learned a few things about becoming a chief medical officer, and that you'll share some of those things with the audience today. But tell the audience a little bit about Cherry Health, what that is, and how you arrived at the position there.
Sure. Cherry Health is one of the largest federally qualified health centers in the state of Michigan. It goes by the acronym FQHC, which is just kind of doesn't roll off the tongue, but Federally Qualified Health Centers is a federal designation designated by HRSA to provide comprehensive care to patients regardless of their ability to pay. So that is HRSA's vision and expectation for all FQHCs. For Cherry Health, that means we provide primary care services, OBGYN, psychiatry, behavioral health services, vision, pharmacy, dental. I know I'm forgetting one. Oh, it's substance use disorder care. So it really is a wide breadth and depth of services that we can provide to patients. And then we span actually the whole state, depending on what program you're talking about. You asked me how I got here, and I actually got to Cherry Health through very deliberate discernment at a pause in my career. So a long time ago, I was a primary care internist in an outpatient setting, and I loved it. And I, worked one-on-one with patients trying to help them be healthy. And I had a moment where I thought, I wonder if I could help more patients if I weren't in a room with one of them, which is really where I tied into like this sort of systems thinking that turns out after a lot of tests and a lot of assessments over my leadership career was, that's kind of how I'm wired. And so my leadership journey was very deliberate to try to understand and get the skills I needed to actually influence and shape systems to help whole populations of patients. After several steps, I was the medical director at a PACE program, which is also a federally defined organization that stands for Program of All-Inclusive Care for the Elderly. The PACE program that I was leading is also here in West Michigan, and started that role in December of 2019, so 3 months before the pandemic hit. And I was taking care of the most vulnerable, the most frail. All of our patients are nursing home eligible, and had to navigate the acute phase of the COVID pandemic. So I supported that organization for about 3 years, and then took 2022 to decide what I wanted to be when I grew up, and was continuing to support and coach my successor at the PACE program, and made very deliberate, reflections and job inquiries to say I want to experience sitting at the executive level, sitting at the C-suite level, and really trying to shape and influence and guide an organization to achieve its mission and also continue to expand and grow. And that's what got me to Cherry Health.
The notion that you were able to step back and think about your wiring and the reflections that you were able to give to yourself, I would submit that it is relatively rare that we as physicians take the time to do that, even in our early stages of our career, when those of us who were at one point full-time clinicians before we gravitated to other work. But I also think that we tend not to do that when we move to our non-clinical careers. So kudos to you for doing that. And I would submit to our listeners who are perhaps in that space, there's nothing to lose and a lot to gain by taking the time, if offered, or do it for yourself, to continuously learn about yourself and how your abilities work, your strengths, and we'll get into strengths-based leadership perhaps a little bit later in the podcast. But I do think those are valuable exercises. And I think as we age, our tendencies may evolve as well. So we can lean into or lean away from some of those things. As you went through that exercise and thought deliberately about impacting more people at an executive level, are there any highlights as to your preparation for the role, things that you did, people that you worked with to really get you ready to be a chief medical officer?
Yeah, sure. When I first started on the leadership journey, I did what I had learned to do throughout my life, which is go back to school, right? So, I want to do something. Let me go get some formal training. That took the shape of lead certification through the American College of Physicians. I started participating with the precursor organization to AAPL, the American Association of Physician Leaders, and really taking the courses, right? Let me get the book knowledge under my belt to be able to be an effective leader. And then concurrently was being very deliberate about expanding my leadership practices, my leadership space and applications. So participating in committees, leading committees, doing collaborative space work within the community in Kalamazoo, where I previously lived, and then applying for jobs that maybe were a stretch, but that was worth the stretch to be able to continue to learn and grow. So, taking the book learning and more importantly, being able to apply it in real world settings was crucial. I also did a fellowship in leadership through Alpha Omega Alpha, which was incredibly valuable for mentorship and for leadership framing, to really think about how to show up as a leader. I had some powerful mentors. Some of them were positive. Some of them were, I don't want to be like that person. And I think most physicians listening to this would be like, oh yeah, that happened to me in fellowship or in residency too. I don't want to be like that guy or that gal. But I had some great mentors as well. I worked with John Toussaint, who has written several books about lean thinking in healthcare, and is the founder and executive director of Talysis, which is a nonprofit that's intended to champion lean thinking and, more importantly, the principles of operational excellence in healthcare. He was a huge mentor for me, and it really shapes how I work every day, because I'm asking questions like, well, what does good look like? How do we know this is true? What data supports or doesn't support us focusing on X versus Y? And that was just a huge piece of my growth and development. I would also add that Brene Brown's work, especially in Dare to Lead and Appreciative Inquiry, and the work of David Cooperrider and Ronald Fry have been invaluable in me being able to show up as the leader I am today.
Very insightful, especially some of the reading material. And for our listeners, you'll find that in the transcript and you can look at those things for yourself. But, it just occurs to me listening to you that as physicians, to survive the path to become a competent clinician, you have to somehow adapt to become a competent apprentice. You really do have to learn from those who've been before you with their accumulated knowledge, wisdom, experience, all the nonverbal subtle cues that happen at the bedside or in the operating room amongst the team members. And you have to learn to model that and be an apprentice. And when I listen to you, boy, we really are set up to be qualified executives because we can stand at attention and learn. We can discriminate what is the right role or the right role model or the right modeling of the behaviors. And I don't know that that's true in every professional discipline out there. And you want to become an accountant, maybe you are lucky to have mentors and folks who show you, but you could technically become an accountant without a lot of modeling, if you will. But to be an executive, particularly in healthcare, I think we're absolutely ready for that, and we've been trained that way. Do you have any thoughts on that?
As you speak, I think about the difference between a fixed mindset and a growth mindset. And I think the most effective physicians and the most effective leaders have this growth mindset of there's always something to learn in any space, and I get to grow and practice and develop forevermore. And I mean, if I stayed practicing the medicine that I trained in 20-ish years ago, right? I mean, whole classes of drugs didn't exist. Biologics didn't exist when I graduated from residency. So of course we need to continue to grow and learn to do any role. I think to be good at being an executive, we need to stay in that space. And I think that our listening skills need to be maintained or expand to be an effective executive as well.
Agreed. So as you describe all of those things, I'm going to ask you a delicate question. As you have arrived at the role of the Chief Medical Officer, step back for a moment, and I want you to consider what others think of you. On my journey to becoming a CMO, I was offered a very simple way of categorizing people. so that I could quickly adjust and adapt to the moment at hand. And I was told, and I believe it's still to be useful, that you can separate people into three categories: diplomatic, aggressive, or analytical. And another way to look at that would be to use physician leader archetypes to describe those categories. And in this case, I'll pick on Dr. Elizabeth Blackwell. She was the first woman licensed and granted the medical degree in the United States, and she was a very diplomatic person to arrive at that accomplishment. There's Dr. Ann Preston. She was the first woman dean of a medical school in the United States, and she was quite aggressive in promoting the value of women physicians, having women in academic roles, and having hospitals devoted to the teaching and training of women. So that's that example. And then the ever-famous Dr. Virginia Apgar, who, as an anesthesiologist, when questioned by her residents, how do we know what's happening with this newborn? She essentially invented the Apgar score, which we all use. And so, with those models and those patterns, what do you think your coworkers would say most fits your leadership type?
So throughout my career, I've had opportunity to take a lot of assessments, right? So even different kinds of archetypal assessments, whether it's the DISC or Enneagram or Myers-Briggs or Strengths Finders or VIA character strengths. And all of those have helped me see myself a little bit better and have helped me recognize that I might not think the way any other physician leader thinks because, I'm this individual and you're that individual. So I guess I wanted to make sure I said that for the listeners to say there could be such profound insight that can be gained into helping yourself see yourself better. And if I were to ask 10 people how they would describe my leadership, I think it would be diplomatic first. So I'm another Elizabeth Blackwell, and visionary. So it is, I can go to work every day if I can say, I see a vision. And from the hope construct, I also see a way to get there. And I think that's where my followers and my organization gets energy and gets confidence in my leadership.
Very cool. Very cool. Besides the pandemic, which you mentioned in a prior role, what is the hardest thing you have faced as a chief medical officer aside from the pandemic?
Well, we got to have a cybersecurity incident.
Can you expand a little bit?
Yeah, we were locked out of our systems for several days. And if you recall the scope of work that this organization does, we have methadone clinics, right? We have clinics that are dispensing methadone 7 days a week. And we had to shift to archaic paper processes, which were built. We had those fallbacks in place, but not for days on end. Our previous downtimes had been, 1 hour or 3 hours most. The cybersecurity event and all of the uncertainty that was happening external and internal to us was huge. And our opportunity was to be able to comfort and reassure our team members that we would be able to get through this and that we could continue to deliver our mission. We could continue to serve patients. I saw amazing creativity in that time, but hands down, that was the hardest thing outside of acute phase of pandemic that I've done as a CMO.
Without naming names or even describing any of your clinically trained partners, nursing leaders and other folks that you work with, did you feel somehow responsible for what was happening to the patients when all of a sudden it wasn't clear how you would dispense a product like methadone or create a treatment plan for someone who was reasonably and acutely ill but didn't necessarily need the hospital? How did that make you feel?
I think you already said it, responsible. I mean, I those first few days running around and figuring out workarounds and working with clinicians who've never worked on paper. I mean, their entire careers have been electronic. And I'm like, it's no big deal. Literally, you can take care of a patient by pulling out a piece of paper and start writing. Write your plan, make it clear, sign it. And people are like, no, this is a big deal because I don't know these legacy systems and processes. I think the burden of a physician leader is that you always feel responsible for the patient or the
Yeah,
patients, for the community. And I don't want to harden against that, because maintaining that compassion and empathy, I think, is a cornerstone for good leadership.
I would agree with you, but extend it that it is a cornerstone for physician leaders in particular. We signed up for it. No one, is holding hand behind our back and forcing us, and we do these things, and we take an oath upon our graduation to uphold the noble ideas and ideals of caring for others. And I have found, and I think other CMOs have found, that in these moments like this, that we do share a heaviness, a deeply held responsibility for the care of others. So when you made that pivot from taking care of an individual patient one day, saying, I wonder how I might have an impact on a whole lot of people with a different way of thinking or a different way of conducting my daily activities, the burden is no less, the responsibility is no less. It's just as deep and it's just as personal. And I would submit to listeners, if you are still feeling that, then you're in the right spot. If you're beginning to struggle with that, then take some time to reflect on that and think about that, because you're uniquely positioned to, as you say, not get hardened and deliver in a world that sometimes is stacked a little bit sideways or against you, but that is still the physician leader's responsibility.
Yeah, and no one, I don't know if there's any other team member in a clinical setting, besides the diagnosing clinician. I'm trying to use generalizable language as I think about my dental colleagues and I think about my behavioral health colleagues, where we know that it's on, the care's on us ultimately, not to the exclusion of others, but that is how we were trained, and that is absolutely how we need to think about improving in the larger setting, in organization-wide or system-wide.
Yes, yes, and yes. What about any particular fires that you were asked to fight and put out? So when a cyber attack occurs, it's a system-wide issue. There are certainly clinical responsibilities, but was there a specific fight between you and another provider, a physician, a staff member, a patient, any particular fire that comes to mind?
For this role, I think struggling with the fire metaphor, because it's like it hasn't been destructive, but it has definitely been hot.
Yeah, heat's fine. How much heat how much heat did you put out, and what did you do to do that?
So I think the heat of this role has really been around the scope of responsibility that this particular CMO position has had, and trying to refine and clarify what the structure, what would be the structure that would work great for the next 20 years. My CEO was wonderfully honest with me when I joined this organization, saying, "Hey, right now we know the CMO position is too big. We get it. Can you come in and help us figure it out, and help us figure out how to build it in a way that's sustainable for you, but also for successors?" I wouldn't say I put the fire out completely, but I do think that I've been able to build logic and structure, and I've been able to develop others to pick up some of the pieces that originally fell under CMO in a way that will serve the organization long term. Still working on it, though.
Yeah, everything's a work in progress in life.
Right. Welcome to leadership.
Yeah, welcome to leadership. Great. When people are in roles like the CMO, and we've talked about the system going down due to the digital attack, and then defining the role and making sure the scope and the structure is there, and you think about the education that you took upon yourself, at some point you would have developed a few leadership tools that you have relied on again and again. Are there any particular tools that you would share with the listeners that you found very useful, and it might strike a chord with them as well.
How large or small scoped would you recommend these tools to be?
Whatever works for you that you think any other person who takes your role in the future would be
Sure.
wise to consider that as a tool in their toolbox.
So getting really good at conflict management and conflict resolution, I think, is a really important skill, and there's a whole bunch, there's a whole toolbox for that. And knowing that most conflict originates internally. So figuring out how to practice awareness, building capacity and awareness and meta-awareness so that you can be aware when the internal conflict happens. So you actually don't exacerbate situations because the story you pulled inside your head. I think a very simple tactical tool is summarizing meetings. If you don't have formal minutes, even a conversation that you had with somebody, summarizing that and sending it back via email and saying, hey, did I get this right? Did I hear you? And did we agree on this thing, whatever this thing might be? It's strongly recommended, obviously, in real contentious or, conflict-ridden situations, but it can just be helpful to move work forward. If an email goes back and forth 3 times, stop and pick up the phone. Like, oh my gosh. And if your blood pressure's gone up, take 3 deep breaths before you do that. And then something that has been very helpful for me as I've stepped into other organizations, and the 2 that I've referenced on my journey, is to know the organization's values and to gut check your behaviors against them. I even sign my emails. I'm fixated on emails right now, but I sign my emails with one of the values because that's actually my gut check. I'm like, is this in service? Is this in collaboration? Is this in innovation? Is this, in professionalism? And if I can't answer it cleanly, then I need to revise that email or revise that message. I do the same with the meetings that I lead to make sure that it's not just the vision that we're shooting for, but the celebration of the good work that's happening today, and that our behaviors align with the values that we espouse as an organization.
So I think we're going to either have to create Dr. Warner's toolbox or Dr. Warner's rule book or some combination, because those were fantastic. And I particularly love your commentary about summarizing the conversation. If whether you're using an electronic health record or you go back old school and you use the analog of writing it down, again, we are trained as physicians to summarize and document our assessment, our plan, and we share that with our other physician colleagues to make sure that we're all tracking in the same direction in the care of a patient. So why we don't do that as executives is beyond me, because I think that's brilliant and insightful. And secondly, in our Chief Medical Officer Academy at AAPL, we ask our students to reflect on their values, their own personal values, and the values of their organization. And you are spot on that it is very important to check yourself against where the organization has its values aligned and how you align with them. And you may not always be in sync, but you do need to check in with it periodically, and it will guide your work and keep you from doing something that you might regret.
Well, even if I'm having a conversation, like say I'm having a performance improvement conversation with someone, which is not work that I did as much prior to being an executive, where I have a significant number of direct reports and setting expectations about behavior, I will always reference the values as I'm having those performance improvement conversations, because I can say, I want you to be successful here, and here's what success looks like, and here's how collaboration fits. Or it's easy for us to go to customer service and think about, which is one of ours, think about that for patient care, but to think about professionalism as our responsibility of showing up and inspiring a positive work environment, that might be an area of growth for some folks. So I find that to be really helpful. And then, of course, you alluded to it, but making sure that your personal values are aligned with the organization's values, and hope that the organization actually lives into them.
Yeah, totally. And you can hold the organization accountable to its own set of values. So I happen to have a copy of your book here, and it is called Conversations Worth Having in Healthcare. I wonder if you could tell the listeners just briefly, perhaps what prompted you to write the book, and are there any other leadership tools or elements that are embedded in the book you wanted to share with the listeners?
Yes, I'm co-author with three other fantastic authors for that book. It's a focus book based on the original resource Conversations Worth Having, that was not field specific, by Dr. Jackie Stavros and Sherry Torres. And we met actually when I was learning about appreciative inquiry and trying to understand how to apply positive psychology to improvement methodology. That was really where I was playing, is to say, how can we work to make things better and not exhaust our teams while we're working to make things better. The value, I think, of talking about a conversation worth having in healthcare is it can happen between the clinician and the patient, but it also can happen between the executive and their employee, or the administrative assistant, or the radiology tech, or any of the myriad of really valuable team members that all come together to provide care and to build systems of care. The most powerful tool that's in the book, and I smile because I love it, is about asking generative questions. So asking an open-ended question to which you do not know the answer, that is looking for what is positive, what is possible, or what is good about the thing, about whatever thing you're asking about, right? So when somebody says, oh, our no-show rate is terrible, which is true for FQHCs in general, then how can we flip that to say, where are patients showing up for service? And then we find it. And then we ask, what is making patients show up here when they don't show up there? And that opens up such possibility and hope that then it actually makes our problem solving a whole lot better, because we're not, kind of slipping into or narrowing our focus into a really reductionist or analytical space, but into possibility and, frankly, assumption testing, which is incredibly powerful and important, so that we get it right. That we get it right for systems, but we also get it right for the particular patient right in front of me. If I ask a patient, what matters most to you, I have no idea what the answer is going to be. But if I hear that and they're able to articulate it, then I'm going to be able to provide better care to them. The same is true when I think about teams, departments, service lines, and the organization as a whole.
Again, very insightful, and we'll put it into the Dr. Warner toolbox because, again, physicians are taught how to ask questions when taking a history and physical, but they're trying to assemble a differential diagnosis. They're trying to reach a particular point of, okay, I'm going to order this, or I'm going to do that, or I'm going to intercede this way. And to free your mind at an executive level role in these conversations in healthcare to say, I don't know the answer. I'm open to the ambiguity. I'm going to discover something that I don't know. So on the one hand, you know how to ask questions as a physician, but you have to sort of suspend belief that you're trying to arrive at a diagnosis. There may be 5 answers, and collectively, you and your team will come to the place where it drives real benefit to people you work with, people you serve, and the organization as a whole.
I was just going to say, I have a strong memory of working at the PACE program, and it was probably 4 days into my tenure there, and one of the quality folks in the quality department said, should we focus on falls or pressure ulcers for our quality targets for the next year? And I just looked at her and I said, well, where do we hurt people more? And she went, wait, what a weird question. I go, well, I want to understand where we hurt people more because I want to make sure that that's where we want to focus the most. And if we don't have clarity on that, how can we? Then, of course, we can flip into generative questions around where have been circumstances where a fall did not occur, or where a pressure ulcer did not happen, and then learn from there.
Brutally honest questioning is also, it's got to go on the list. That's a brutal, honest question, a good question, and more than likely the right question. what would you say to your younger self about becoming a chief medical officer? Could you go back in the time machine, talk to yourself, in your youth? What would you tell that person?
Well, I separate that into personal and professional guidance. And I would tell my personal self to develop and be fiercely protective of self-care strategies that can help build resilience and strengthen well-being. Get enough sleep. Stop the caffeine. Limit alcohol. Move your body regularly. Meditate, even if you can't, focus for 5 seconds. And all of these things will allow you to show up better as a human being in all of the roles that we play. I think for both personal and professional advice, I would say find daily moments to celebrate and savor. The gratitude journal work that has been shown to be incredibly effective at actually elevating mood, protecting against depression and such. It could be a gratitude. It really could just be like, you know what, I did a good thing here. I had a 5-minute interaction with somebody in the break room, and we both left elevated compared to when we came in. Because on the leadership trajectory, you just don't get that cadence of closure and hopefully success that you get when you're taking care of patients, right? One after the other. And finally, professionally, I would say stay humble. So that allows you to keep asking better questions and stay grounded in your values. And I think the most powerful thing that we can do as leaders is to develop the people around you and assume that every interaction that you're having is a development one.
Love it. I love it. So I love your comments to your younger self. We're almost at the end here, and I want to give you the option of picking one of the last 2 questions before we wrap it up. You could answer question 1. What would you describe as the hardest aspect for you personally of your job at a personal level? What do you think is the biggest fire in healthcare in general right now, in your own opinion, and what can a CMO do about that, if anything at all?
I want to go for the first question. The hardest aspect for me personally, this particular CMO in this particular organization right now, is honoring the pace of cultural change, because it's slow, and I see that future, and I'm so eager for us to get there, and it's really important that everyone else can see and feel that as well. So I need to be able to slow down to help with those cultural shifts and the cultural changes. I also am not always in the room when a cultural epiphany has happened, and I may never hear about it, or I hear about it a lot later. And that's hard. That's hard for me to know, is it working? Is it aligning? And I'm really grateful when I get a little tidbit that says, yeah, it is.
Well, thank you for sharing that, because that's a personal level question, but I think you nailed the answer. Listen, being a chief medical officer is no small task, and we covered a lot of ground today, and clearly it takes intentional preparation. Although some of it does feel like a trial by fire, whether you like the analogy or not. My old boss told me it's just like a career in firefighting. You start by going to firefighting school, you do all the training, and you drill, and then you're ready to fight the fire, and you put on the uniform, helmet. You start out as a fireman or as a firewoman, and one day somebody says, hey, would you like to be the squad leader or captain? And you go, sure. And then perhaps someone says, hey, how about becoming a fire chief? And my boss always told me you cannot be the fire chief without first learning how to be a firefighter. Would you agree with that?
Absolutely. And the amazing gift of being a clinical leader is you never stop being a clinician, even if you are not actively seeing patients at this point in your career. And that is a perspective that not all executives have.
Totally agree with that. Well, it's been a real pleasure having you on the show, Elizabeth. I hope you enjoyed it.
I did. It was so nice to talk with you, Lee. Thank you.
You're welcome. Well, you have been listening to the Fire Chief Podcast, the only podcast dedicated to the CMO. Want to learn more about what it is like to be a CMO? Want to be on the show? Email me at leescheinbart@gmail.com or connect with me on LinkedIn. You can listen to the podcast on Apple, and you can also watch the videos of the shows on YouTube. Our show's website is thefirechief.podbean.com. I love talking with CMOs from all over the United States, so please connect. Leave your reviews, leave your comments, and share this with your colleagues. And in the words of Sergeant Phil Esterhaus, let's be careful out there.